Thank you so much. Yes, my name is Kristen Wall. I am from Emory University, and I work with the Rwanda-Zambia HIV research group there. And I just want to say that I am just thrilled and honored to be here today, speaking to all of you and presenting this data on HIV seroincidence by antiretroviral treatment status among serodiscordant couples in Zambia. So we have no conflicts of interest to disclose. And I want to begin by overviewing some acronyms I'll use throughout the talk. So TASP, as most people know, stands for Treatment as Prevention, or Antiretroviral Treatment as Prevention. And for the purposes of this talk, ART has been provided to HIV-positive persons for therapeutic reasons only. So it's something important to keep in mind. And then also CVCT, which stands for Couples Voluntary HIV Counseling and Testing. And in this intervention, couples receive joint pre-test counseling as well as joint post-test counseling with facilitated serostatus disclosure. So I want to start and sort of use this schematic to outline my talk. I'll briefly overview the research evidence around CVCT and Tasp and how this evidence has led to the current WHO recommendations, which are now being implemented to varying degrees in real-world settings. And of course, this is leading to even more questions. So CVCT has been shown to reduce HIV incidence in serodiscordant couples by 2/3. And we know from the results of HPT and 052 that TASP has an efficacy of 96%, and this is in a randomized controlled trial with very high adherence. So these results and the results of many, many other wonderful studies in the peer-reviewed literature led to the WHO publication of their 2012 Couples HIV Counseling and Testing Guidelines. And in these guidelines, recommendations 1 through 3 support CVCT for all couples, purely for the prevention impact that CVCT provides. And recommendation 5 supports TASP for serodiscordant couples regardless of CD4 count. So now, as our moderators mentioned, many people are asking, well, what is the real-world effectiveness of TASP in serodiscordant couples outside of a research setting? And so that's the question I'm going to focus on today. I'll present data around that question, and then I'll briefly talk about how these findings have led to more questions for us, and I'll just briefly talk about 2 that have to do with antiretroviral treatment adherence and ARV resistance. So CVCT has been offered in Zambia since 1994 in standalone research facilities. But in 2007, this intervention began its transfer and scale up into government clinics in the Southern Province and in Lusaka Province, which are shown here in the South, along with the adult HIV prevalence in those provinces. And in 2010, this government scale up began in the Northern Province of Copperbelt. So over the last 4 years, roughly, 2011 to about the first quarter of 2014, the Zambian government has tested over 150,000 couples. And the serostatus distribution of those couples is shown here. And it's important to note that some couples who were, or individuals who were antibody negative at their first testing visit were actually in the window period of infection. And that allows us to sort of tease apart the effects of CVCT. So what I mean by this, for example, just looking at the serodiscordant couples, which represent 12% of the couples tested, before CVCT, they experienced an HIV incidence of 11 per 100 person years. And after CVCT, this was reduced to 2 per 100 person years. So this represents an 82% reduction in incidence, and this is a statistically significant reduction. And I also want to look at the same process for concordant negative couples, who represent 74% of all of the couples tested. Again, CVCT had a prevention impact for them. They started with a relatively low HIV incidence of 1.4 per 100 person years, and this was reduced by almost 70% after CVCT. So using the actual program costs, we calculated that the cost of preventing one infection in this group in Zambia was just under $400. So I'd like to focus now on just the discordant couples. So this 82% reduction is not just the effect of CVCT, it's also the effect of TASP, because in some of these couples, the HIV positive partner was already on antiretroviral treatment for therapeutic reasons. So like I said, just looking at the effects of CVCT and TASP sort of teased apart among these serodiscordant couples. I'll mention that 12% of these couples reported prior CVCT, and in 21% of these couples, the HIV positive partner was already on antiretroviral treatment before counseling and testing occurred. So if we were to pull out all of the couples in which the positive partner was on antiretroviral treatment and just look at the effect of CVCT, we see that before CVCT, couples who are discordant and don't know it yet and are not on antiretroviral treatment experience a seroincidence rate of 13 per 100 person years. And then after CVCT, they experience a 73% reduction in HIV incidence. And this is also statistically significant. Now, if we're to do the same thing for ART, or treatment as prevention, we see that prior to CVCT, that couples who the positive partner is on antiretroviral treatment, they experience a 30% reduction in incidence. So what this is saying is that among serodiscordant couples who have not yet been jointly counseled and tested, many of whom who don't know that they are in a serodiscordant relationship, the effect of therapeutic ARVs only has about a 30% prevention impact. So a question you might ask is, well, if we provide those couples, this group, with CVCT, what kind of prevention impact would we see? And we again see a statistically significant reduction in HIV incidence by targeting CVCT to discordant couples who have not yet tested where the positive partner is on antiretroviral treatment. So, of course, there are costs associated with providing any of these interventions. And so, again, using the actual program costs during the scale-up and the effectiveness estimates that I'm showing you here, we were able to calculate a cost per infection averted of almost $700 for providing CVCT to discordant couples where the positive partner was on antiretroviral treatment. So in conclusion, and this is just sort of recapping the data I've just showed you, CVCT is effective in a real-world setting, and this was irrespective of ART use. So it was effective in couples where the positive partner was not on ARVs, or even if the positive partner was on ARVs. And as you might expect, it's not terribly surprising that TASP in a real-world setting is not as effective as what we've seen in a randomized controlled trial. And we saw this here among serodiscordant couples who had not yet been counseled and tested. So moving on into the sort of future directions and questions that we're now asking ourselves. So like I said, not surprisingly, the effectiveness of TASP in a real-world setting is lower, and one of the main reasons you might think that this is true would be adherence. So we would like to know, what are the rates of non-adherence among these couples? What are the factors associated with ART non-adherence? And how much can retention and adherence be improved when ART patients are provided with CVCT? And I just want to point to some studies in the literature that indicate that ART non-adherence in Zambia is quite high. About 40% of initiators are non-adherent in 1 year, and about a quarter of patients drop out at 1 year in Zambia. Another question you might ask is, in 44% of the transmissions that we observed, the HIV positive partner was on antiretroviral treatment. So were any antiretroviral resistant viruses transmitted? And again, I'll point to some recent literature that indicates that in Zambia, antiretroviral resistance is increasing and is about 5 to 6% in ART-naive HIV positive persons. So I'll conclude with these recommendations. We recommend, based on this data, that CVCT be promoted and provided in all settings that offer HIV testing. And this is in support of those WHO 2012 guidelines that I mentioned, recommendations 1 through 3. These promoting couples testing for all couples was also reiterated in the WHO 2014 key population guidelines that just came out a few days ago. We also recommend that CVCT should be a priority in ART clinics. And this is in support of the WHO 2012 guidelines recommendation 4. And we also recommend that resource allocation models should be inclusive of CVCT, of TASP, and using these sort of real-world estimates of effectiveness that we're now observing. So I'd like to acknowledge my collaborators at the Rwanda-Zambia HIV Research Group. I'm presenting this data on behalf of a really wonderful team. The Path Arise program for their funding, that's through the Canadian government, the Zambian Ministry of Health and District Health Management teams, and of course all of the CVCT clients and clinic staff. And this is just our funding slide. I'll also acknowledge the integral support from the International AIDS Vaccine Initiative, or IAVI. And I will briefly leave up this slide if anyone's interested in other posters and presentations that the Rwanda-Zambia HIV Research Group is presenting here at the conference. They're listed here, along with the Path Arise satellite session, where we'll also be presenting more data. Thank you so much.